Fine. Okay, so hello everyone. This is the sixth time we do this, and people have been finding it very useful up till now. So hopefully we're going to carry on. We'll see how it goes. We've got Ritika today, who has kindly agreed to join us this morning. She's a consultant, cornea consultant in Brighton, correct? So it won't take much of your time, but usually I start off with the very classical question of walk us through your journey. So when did it start? How did you start your Caesar journey?
Right. So I joined as a specialty doctor in late 2020, November 2020. Um, I tried to sort of start pretty much as soon as I joined, but I realized sort of 1 or 2 years down the line that whatever I was doing was not organized. So I was spending a lot of time doing things which weren't very important, and then obviously not spending time. Um, I think the main thing started after I attended the CESR workshop, which was in 2022. So almost 2.5 years later after I began. And I found that really useful, the Royal College CESR training day, CESR workshop, because that gives you a nice mental picture of how to organize everything. With regards to the things that I did from the very start was keeping a log of some of the patients, some hospital IDs, things like where I know that I could go back and retrieve those letters if needed, to show a wide variety of sort of patient caseload across various subspecialties. Why that was important for me was I only worked as a specialty doctor for 6 months, wherein I did a bit of medical retina, glaucoma, and general clinics and eye casualty.
That was in
After that,
Brighton.
no, this was Red Hill. This was only
Right.
for 6 months. And after that, I joined as a cornea fellow in CESR. So most of my CESR evidence is actually from my fellowship and my first year as a locum consultant. Um, and so I haven't done the traditional 20 clinics of different specialties, but what I did was I made a case logbook of various specialties. So I kept a record of hospital IDs of patients which pertain to, let's say, glaucoma, oculoplastics, patients that I was seeing in my cornea clinic. So, patients with multiple comorbidities, or, for example, neuro-ophthalmology, pediatric, retina. A lot of that was covered from my eye casualty sessions. So
But you
I
still but you still split the logbooks, haven't you, per specialty?
Yes. Yes.
Yeah.
So what I did in the end was, so that was the most time consuming thing for me. And I had to do that because I didn't do specialty clinics a lot in the UK, apart from doing medical retina glaucoma clinics in the first 6 months. Because after that, I was doing a dedicated cornea fellowship. So that was the only specialty clinic I had. So I made a logbook of, just to show like a breadth and depth across specialty. So I made sure that in cornea, I was covering everything. In medical retina, I was covering, all the usual things that, 15, 20 cases at least per specialty to do that.
20. Okay, okay, 20 is not too bad actually. I mean, 20, do you think 20 is a few number, or was it your average 20 per specialty?
20 would be my average. For things like neuro, I think I showed like 30, somewhere in 30s. Cataract, I think I only managed about 20. Peds, I only managed about 20 because obviously you don't see as many cases. So, peds was things like looking at conjunctivitis in A&E.
I'm quite surprised. I'm surprised that this number was accepted because, again, traditionally they kept the number around 100, 120 even.
Yeah.
So the fact that you've put only 20 cases per specialty, that's great.
Yes, but I would say that this was on top of, my other evidence. So what I did was my training in India. Um, we don't have a job plan and timetable the way it is in here. So what I did was I made a document, sort of in the same currency that they understand here. So I made a job plan of my entire 6 years of training in India, trying to sort of mirror the kind of terminologies that they use. So, on call, if we did on call every sort of 6 days, so on call 1 and 6, and divided the AM PM session, ward round, specialty clinics. And I showed all that because even though some of that evidence was outside of the 5 years, it represented the depth and breadth of my previous training. So I think they're quite sort of sensible and understanding in the way that if you show that you have done a very comprehensive training, even if it's obviously, in most people, in most cases, it would be outside of that 5 years. But that's understandable because they do understand that, you've come in here, it takes time to settle in, you'll start gathering your evidence. What they want is that you have showed that you have maintained you have maintained your
Yes.
knowledge,
Yeah, yeah.
and you have shown some sort of recent evidence in the last 2 or 3 years of your, when you're submitting your application to show that, yes, you still have good knowledge about all the other specialties and not just sort of, one specialty if you're already working in that.
Yeah. And since you've been starting in Brighton, you've stayed in Brighton, obviously. And when did you submit your application?
So I submitted in February 2024. Yeah.
Okay.
And it's 25 now, and I got the outcome just
Yeah.
exactly within a year, so in Feb this
Excellent.
year.
Excellent. That's not too bad at all. And again, I'm not sure if you're going to remember or not. So how long did it take um, the application to stay with the GMC,
Yes, I
roughly?
think that. So they said you will have an assessor assigned, I think around 3 months. So that's what happened. So I got the first email in around 3 months' time. And then they take around another month to analyze everything and get back to you.
Yeah.
And then obviously you're given some time. So I took 2 months, which was, I think that was something which I could have shortened on my perspective. So I took 2 months to reorganize the evidence because there were a lot of comments. And then I
Like
also
what?
added
Tell us a
additional.
few comments. Yeah, tell us a few
So
comments.
things like, so I'd clubbed my presentations. So things like move the audit presentations into teaching and audit, and all my conference presentations into sort of external CMA. So that was one thing. Then I submitted different logbooks, the subspecialty logbooks that I was talking about. And my assessor said to combine everything into one. So
Yeah.
then what I had to do was I made like an index in front of every logbook. So they were sort of separated, but it was all in one document, exactly in the same sequence as it's mentioned in the SSG. So you start with oculoplastic, then cornea, cataract, and go down the
So at the
list.
end, they asked you to combine all the logbooks into one.
Yes, because
Interesting.
I think the idea is that when you submit the evidence, if you have multiple logbooks from the same hospital from the same time, it gets very confusing. So they want to try and restrict. So, for example, if you worked in 3 different hospitals, if you are submitting a case logbook from one hospital, they want everything to be in one document. If you're
Yeah.
submitting a logbook or job plan for every hospital, they want you to try and submit only one document for the category of evidence that you are submitting. So I think
Yeah.
that's why. So it was things like that, and then which took a lot of time. But I think that is something. Once you submit your application to the GMC, I think most of us would have a fair idea about, that I might need to change this. So if you keep working on your application, I think once you submit, probably for 1 month, you're not going to come back to it because it's such a huge thing and you would want to forget about it. But I
Yes.
think GMC takes a good 3 to 4 months to come back to you. So if you keep working on your application, if you've done anything new, if you've presented something new, keep updating your CP so that you don't waste any time of your own. So that would I spent 2 months nearly, and then they take another sort of few weeks to a month to come back saying that everything's fine. Um, the other thing in terms of the delay in my application was, I think the way it's communicated, you are, as the candidate, you are not kept in the loop of whatever is being sent to your referees, your verifiers. So in my case, they sent out the wrong structured referee forms in the first place, and they sent out medical ophthalmology instead of the normal ophthalmology SSG.
Okay.
And as you can imagine, most of your verifiers, everyone will be busy. So it was only a few weeks later that one sort of verifier was like, this doesn't sound right because, they are asking things which I wouldn't expect you to have done and stuff. And then I asked them to, can you share a copy of the referee form they have sent? And then I went back to GMC. So I think you sort of have to have a very good communication with your referees, with your
I agree.
verifiers, and
Yeah.
you have to stay on top of it because that takes a lot of time. because GMC doesn't keep you in the loop. I did feedback this to the GMC after my application, so not sure if they.
Yeah, mistakes do happen, but unfortunately, you cannot be compensated for the time that you've lost.
Exactly.
So that's the issue. But yeah, it's a very valid point that you need to keep chasing up your referees and verifiers and the GMC as well. In case these sort of silly mistakes happen.
Yeah.
I definitely agree. But I mean, it's very interesting how, because no matter how frequent we do these things and different people we talk to, each application has got a totally different story. Yeah. So, for example, when you mention 20 cases per specialty, that's weird for me, because I thought they needed many more, unless the cases that you saw, was it a logbook or was it a case history sort of thing? What, how
What I
much
can
did they
do
write?
is I can very briefly share my screen
Yeah,
to
yeah,
give you
yeah,
an
yeah. If
idea,
you have.
because I think this is something um, I sort of made up as I went, because um, I didn't know anyone closely who was doing CESR at the same time. So this is something I did, like it was, I thought this would be fine, and apparently it was. So sorry, just give me one
Yeah, take it.
moment. Yeah. So if I can share.
Just tells you how different the applications are, and that not one size fits all, this sort of thing.
Yeah. S- Can you guys see my screen?
Yes. Yeah, we can.
So
Yeah.
this is what, in the end, I labeled this casebooks group by specialty. And so there's an index with paid numbers. So basically, for example, oculoplastic, what I've done is just to give an idea of the age of the patient, what the diagnosis, what my role in the management, and what it links to. So if there was a CBD linked to that letter, and what learning outcomes. So this is what I made, and I sort of labeled all the letters, and I'll show you
So
what it means.
what do you mean other subspecialty?
So for example, you know, look at the first case. So it's thyroid eye disease with someone with filamentary keratitis. So I just put it
Okay.
down. So it sort of
Complete.
shows, that's what I felt. I mean, because that's what they want to see at the end, that you can work at the level of a consultant ophthalmologist as a general ophthalmologist. So
Yes.
I'm not sure if, this is just what I did. Again, it's not a format, or it's not something that
Yes.
you have to follow.
No, I like
But
it.
this sort of seemed logical to me, because if, as an assessor, you can just go through the index, you can see there's a good variety of cases there. And then if you want to refer to anything, so for example, there are 23 cases in oculoplastics, and then there are all the letters and things that I showed, and obviously with redacted information. And I labeled every letter with the
But
specialty.
did you combine the letters with the logbooks as well in the same uploaded file on the
Yes, so this is the actual file that I submitted. It's 413 pages, and this is case groups grouped by specialty. So this is what I did. So I combined
was that
everything.
something was that something they asked you to do, or did you do it on your sort of
The
own
case
choice?
books I made on my own, because it seemed sensible to me to sort of, because this is the evidence I have. And, at the end of the day, it's like you have to organize whatever evidence you have, because there's no clear format. So this seemed sensible to me. But they asked me to combine all the specialties. So first round, I submitted everything separately. Second round, I clubbed everything. So for example, now this is cornea. So again, obviously I was a corneal fellow. I had slightly more cases. So 34 cases for cornea. And then if we keep going down.
And that's
So
another weird thing that they accepted you submitting the logbooks with the letters, because usually, if you remember, when you upload the
yeah,
documents, they're usually split. Even in the verifier form,
yeah.
they're split. So patient letters is something, and logbooks are something else. So
Yes. Yes. So they accepted it, because this was my way of showing my, understanding of different specialties. I did submit a few letters, something which were pertain to, communication, a complaint or something of that sort. I did submit that separately in letters, but this is what my sort of, this was my alternative of showing. I have done 20 clinics, glaucoma, 20 retinal clinics, because that's something I did not have from the UK. So this is what I did, and I think
looks
yeah.
pretty good.
Okay, I'll stop sharing. Right.
How about let's talk a bit about surgical numbers. So, did you find difficulty getting your surgeries, like the squints, the plastics, those sort of things?
Yeah, so squint, plastics, glaucoma, obviously these are the three, main areas. Retinal lasers, I ended up doing a lot from A&E, retinal tears, etc. Oculoplastics was still relatively okay because a lot of hospitals do, cases, blephs, ectropion, entropion, lid excision in minor ops. So I planned my study leave in such a way that I would go assist them, do some cases, and I got signed off, and that's how I did the oculoplastics. Squint as well. There was one theater a month where I found an opening where the Squint consultant, this was during my fellowship, they didn't have a trainee. So every month I would take annual leave or something on that session, or move my admin there or something. I managed for 6 months, 6 or 7 months, I think, and that's how I did my Squint numbers.
Yeah.
Glaucoma, I had a few from back home, and then I did a few trabs, and then mainly lasers. So even though I didn't do, I think, the full actual number required from the in the UK, there was a comment in my final assessment saying that, even though the numbers are not enough from the UK, there is previous evidence of showing surgical numbers in the specialty, and that I have shown that I've maintained the recency because I had a sign off within the last 2 years. So I think they're quite reasonable in that way. And things like evisceration, enucleation, I did one on a patient here, but then I did have some numbers from India, which I showed. But the fact that I did one in the last sort of 1 year was enough.
There was a very common question I always get asked as well is, let's
Yeah.
say I've never worked in the UK, would I be accepted to submit all my CESR application from overseas? I mean, obviously, I don't know someone in person who, personally who did that, but
Mhm.
I cannot see why not, So CESR is an international sort of thing. So any evidence from anywhere can be accepted.
Yeah.
However, we'll all agree that it wouldn't bear the same weight as in the UK, but you are still allowed to get
Yeah.
all your documents overseas. And lots
Yeah.
of people have. I mean, actually, most seniors here who got the Caesar have used some evidence from outside of the UK. I got some back from Egypt as well. The hard to get competencies like
Yeah.
the tap and
It
inject and
it
yeah.
almost feels unnatural not to, because obviously, you have trained elsewhere. So I think it makes sense, even if you're not showing the surgical numbers, I think it makes sense to show how comprehensive your training was. Because so my assessor in the first round, she said a lot of the evidence that you've shown from AIMS is old, because I clubbed everything from sort of 2014 to 2020. For example, my job plans, my timetable, because that's the time I spent in India, in AIMS New Delhi. And I just went back and I said that even though it's old, a part of it falls within the last 5 years, and it shows my overall training, and it shows that, I have went through a structured training in India, and I think it's relevant. And she said yes, that's quite reasonable, and she accepted it.
Yeah.
But obviously I didn't show logbooks and, any sign offs or workplace based assessment from that time.
Yeah, yeah. Even the surgical numbers. So let's say you were an oculoplastic surgeon back home and you've done hundreds. So if you submit some evidence of those numbers in a logbook, even outside the 5 years or 7 years, um, but these are old, but you need to submit some more cases recently to show again the maintenance of your skills and knowledge. So
Absolutely.
it doesn't mean that it's very old, no, I'm not going to use it. It will still be useful because now they know that you're a very senior person and you just are still in the game, so you've done some cases recently just to keep your skills up. So these will be accepted, but obviously not sort of evidence from 20 years ago.
Yeah.
Let's say 10. Let's say 10 is an average good number. But you have to submit some more recent cases. Um, okay, how about the sign-offs? So were you like any other sort of senior person? Were you struggling to go to other sort of colleagues, more senior colleagues, to get them to sign you off for vision and pressure and those sort of things? How did you manage those annoying sort of sign-offs?
Not particularly. I would say because I was in one place.
Yeah.
Most of my sign-offs were from Brighton. I was in one place. I was doing a fellowship there, so I was lucky in that way. It was not a problem. Um, I got vision and pressure signed off from most of the trainees I were working with because it just felt stupid to get a vision and pressure signed off from a consultant when you're working as a fellow. And you can, ST4 and above can sign off for things like VA, IOP, visual fields, though I don't think it's needed any longer
Yeah,
in the
yeah,
newer
that's
curriculum.
that's the good thing
So
about the
that's,
new sort of
yeah,
curriculum. Yeah,
yeah.
so you, again, just to again make it clear for everyone, for the new curriculum, I'm sure many of you out there will be submitting with the new curriculum. You don't need any more the sign-offs for level one and two. So the vision, the pressure, the fields, those sort of things. If you open the EPA forms, um, all these sort of sign-offs, you don't actually have to submit um, the forms for them in the CESR application. However, you will still struggle with your supervisor, because if your supervisor hasn't seen you do these stuff and they're a bit sort of they want to make sure that you've actually done these things, they might ask you to submit these or to show them these sign-offs. So it will depend on your supervisor. If they're happy, they can sign it off, great. But if they're not, they will not sign the EPA. And then at that point, which is not fair sometimes, I have to say, because some supervisors are very chilled, they know you quite well, others are not. So there's this sort of discrepancy sort of thing, which I'm not sure many people will like, but that's just how things go. But so in general, things are easier, they're not tricky. And as you can see, so Ritika, she submitted only like 20 cases per specialty, which is great, because I submitted like 100, even more. Others have submitted more. So as they always say, it's about the quality of the evidence rather than the quantity. Yeah, I'm sure you would agree. Fine. Okay, let's talk about other stuff. So, audits. Again, a very common question about audits. So, how many audits have you submitted and how many did you lead? Again, they were saying recently that you have to, at least the one with the full cycle, you have to lead on it. So, tell us
Yeah.
about that audit particularly.
So I did 5 audits and then closed the loop. So 5+1, which was a re-audit, and then the personal cataract audit. And this was in a period of sort of 3.5, 4 years. So everything was from the UK. Um, I was the lead on 4 of these, and one I shared with I was basically I just shared with someone.
Nice.
So,
So, I mean,
and I,
being a lead, what do you mean? So, in that sort of full cycle audit, did you start the audit and then you finished it at the end?
yes.
Right. Okay. Fine.
And
Which makes
yeah,
sense.
I submitted the re-audit in actually my second round of evidence because I submitted my application in Feb. I hadn't closed the loop by then, but I know, it's something that I would be able to do in 1 to 2 months. So I closed the loop and I submitted the re-audit in the second round. So just to give you an idea, I mean, if you're 95% down and you know the rest 5% is sort of achievable within the next 3 months, you're better off submitting your application and working on that remaining 5% in that time to save yourself some time. So yes, coming back to the audits, I think I deliberately in my corneal fellowship, what I did was I picked up 2 audits from the eye casualty, uh, which were not corneal because you have to, if you show all the audits from sort of 1 or 2 subspecialties, and again the quality of the evidence reduces. So I had one audit which was retinal, one glaucoma, one neuro, and then 2 corneal. And then the topics were sort of very basic, so you can get a lot of you can just get a simple idea.
Keep it
Eye
simple.
casualty, yeah, eye casualty for me, it's like it's actually a treasure, eye casualty, if you do. So you can get lots of cases, different specialties, you can do quick audits. So I think, yeah, that's something that I would keep an eye out for.
Yeah, yeah. I agree with that sort of phrase that casualty is a treasure, because you can get lots, actually most of your stuff can get from casualty, by the way. Yeah.
Yeah.
If you do casualty, you can get casualty cases, you can get general cases, you can get all the weird neuro stuff, which you will never find in the clinics. So being in casualty is not bad at all, especially for the juniors out there, because they, oh, I'm always in casualty, I never get to operate or whatever. Actually, this will really serve your Caesar sort of pathway. It's very useful. Um, okay, how about courses? So have if I ask you what sort of mandatory courses would you recommend?
So I would recommend doing the train the trainers, the college. I think
Yeah.
it's quite useful. I mean, if even if you're, not just for CESR point of view, but eventually if you become a consultant, you'll have trainees under you. And if you've not trained in the system, I found it very useful. So I did two train the trainer courses. One was separate 1 day course with the RC off, and then one was a 2 or 3 hour session as a part of the college conference, which was included in the registration. So college does that. It's sort of included in the registration for that day if you book it in advance. So I did two of those. And then I did the online NHS Leadership Academy Leadership and Management course. So it's an online module. It's
Which one is
free.
that?
So that's Edward Jenner.
All right. Yes, I've heard of that one.
Yeah, so if you just search sort of NHS Leadership Academy, I think you have to sign up on Future Learn with your NHS email, and then you get a free sort of link otherwise it's a paid course, but through the NHS you can get, and there are different modules. So I did 2 or 3 of them, not the entire thing, because every course takes long. So, it's sort of 6 weeks, couple of hour, 1 hour or so, or I think 4 hours per week or something like that. And then you can do it in your evening, in your free time.
Yeah.
Yeah, that was quite useful. So I did that in the background once I was coming close to collecting sort of 80% of my evidence.
Any other courses?
Um, Nothing
Have you done the GCP
particular.
one? The
Oh, yes,
GCP
of
one?
course, of
You've
course.
done,
Yes,
yeah,
I've done
yeah.
the
That was the one I
GCP.
was waiting for.
Yeah,
That's fine.
yeah,
So yeah, everyone has answered the same. I gave the same answer. So
yeah.
leadership, TTT, and GCP. These are the main three essential courses. How about the ELFH, the e-learning for health? Have you used any of those?
I did start, but then I didn't. I thought I would do stuff like laser safety, and just to add, because there is a outcome for laser safety, but I didn't do that in the end because the fact I think that you're doing lasers and stuff, I think that is sort of, and you do a trust, every trust has their own sort of brief laser induction safety. So you do that. The other thing was through the indemnity provider, I had just done like, few half an hour, 1 hour courses, things like consent, things like confidentiality. And in my first round, I think I forgot to redact. For example, I submitted a critical incident that was reported by me, and I redacted the names of the staff and everyone that was involved, but I did not redact the incident number. So there were 2 or 3 things like that, which was something not obvious. But then obviously this comes back from GMC. And when I submitted my evidence again, I just did like an hour's course on confidentiality and data protection, and then I sort of submitted along with a reflection, because this is something that they really like. If you forget to redact something in the first, so it just shows that you understand the importance of data confidential. So I think these little, and they are sort of like buzzwords, things like, and it's in your mandatory training as well. So if you show something additional, I think that there are some outcomes where you can link these courses to.
Yeah, yeah. And reflections? Have you written down many reflections?
So my cataract complication, obviously that was one reflection diary, and then things like critical incident and complaint. So it was not something I was directly involved in, but I just wrote a reflection. So in the same document, I basically just put like a box
Mhm.
um, on top there as my reflection. So nothing, sort of no separate document or
Oh,
anything,
so you
it's just
haven't
my reflection.
submitted. Oh, okay, you haven't submitted a reflective diary sort of thing.
Yeah, no, the reflective diary was only for the continuous cataract complication
Right.
audit. But then all the other reflections I submitted along with the relevant documents.
Nice.
Um, yeah.
Okay. Trying to think of any more common questions. And your exam, I'm assuming you've used the FRC off to tick off a few boxes as well.
Yeah,
Is that correct? Yeah.
definitely yes.
Right. And how about the clinical skills, the first sort of bit of the learning outcomes, the first sort of 15 sort of sign-offs? Did you submit only one CSR for each or two?
So
Do
for
you remember?
most, I did have two. For most of them, I did have two sign-offs. But for things where I basically used the same for, for example, if you do a consultation, you can get things like vision, pressure. So I used one for two, but I did have two for most of my outcomes. I think there were just a few where I probably only had one sign off, but then I showed a letter or something as secondary evidence for that outcome.
Right. Okay, fine. Um, I've sort of finished my sort of common questions that I ask every time. There was a very interesting idea that I've heard recently about the waiting time. So again, people are complaining of the waiting times just to find an advisor from the GMC and allocating an assessor at the college. Someone mentioned that they would be happy to pay extra money as a super priority sort of service, as we, we've been seeing in the UK VI visas and stuff like that, priority service. If you had this option, would you have paid more money for it, or would you not bother?
Probably not, because it's quite expensive as is, and I think
Yeah.
it sounds a bit unfair because it's like a system which is not working. I think the system should work at a baseline level first properly, because if everyone starts doing it, then the regular applications will just keep taking longer and longer and longer. So I think it's more, I don't know. Obviously, I've done it, so yeah, it's just a hypothetical question for me now. I don't know
Yes.
but I probably would not have gone for that.
Right. Okay.
Yeah.
Let me read to you one of the questions on the chat. Sweeney has asked, could you tell us what surgeries you had to be a primary surgeon, and what were you the assistant? So
Yeah.
plastics, strab, those sort of things.
So I did all the numbers. I showed all the numbers for plastics and strab as a primary supervised surgeon here. I
Yes.
did do a
PS.
bit of assistance as well, but you can't assist for the sign off. So the 20 strabs and the 40 oculoplastics, you have to be the primary surgeon, even though if it's supervised.
Yeah, yeah. So PS. It really wouldn't matter if it's P or PS. Again, if you
Yeah.
read quite, between the lines on the College of Guidance, P means that, the consultant was unscrubbed or was waiting outside or something. PS would be that, they've been scrubbing next to you and helping you out.
Yeah.
Again, a very common question I've got asked many times is, what if I've done some steps of the surgery? Would that be counted as assisted or PS? The honest answer, the truly honest answer is no one is going to go back through the notes and know exactly which steps that you've done. Okay, so let's be honest with ourselves. However, let's say your supervisor is happy, they don't care, they're very chilled. They will allow you to put whatever you want in the logbook. Okay, but between you and yourself, do you think you've actually trained well? Remember, it's all about training. It's not just about a tick box exercise. So are you, because you're going to be a consultant very soon, so are you trained enough to do this sort of surgery? Something like squint, yes, as a general consultant, you will be on call, and then you'll have a ruptured globe, and then you'll have to unhook the muscle. So can you actually do this unsupervised? That's the question you have to ask yourself. So it's not just about putting the numbers in, it's actually about, you know, doing the stuff. Because if you're a permanent consultant and you're struggling to do these things, that would raise lots of questions. And the credibility of the CESR sort of consultants will go down. So uh, cataracts, again, many have been doing cataracts, very juniors, just assisting, putting the lens in or hydrating the wound or something. They want to put it as PS. That's not going to work. I don't think that would you agree? What do you think?
Yeah, I mean it's a gray area, isn't it? So I think I completely agree with the fact that I think you should have the training. Often what happens is probably if your supervisor knows that you have done a good number of cases already, and in the interest of time, they allow you to scrub in, do a few steps, because obviously I will not be as quick with an oculoplastic procedure or a strap procedure as I would be when I was, doing them in my training, right after the other. And as long as they are happy, because to sign you off with a few steps, and I think that's fine, given the fact that they're happy because they know you've already done this in the past and you have the knowledge and you have the surgical skills. So it, I don't think it's black and white,
Yeah.
because a lot of us who are doing CSER already do have a lot of, clinical surgical experience from back home. And often it's more the practicality of it, that you don't get that time or session wherein you can go in and take your own time and do a different specialty case, which obviously you've not done for some time, so you will not be as quick. And I think sometimes it's just being more pragmatic. So a lot of consultants, they're quite reasonable letting you do a few steps, and most consultants, just the way you're doing those few steps can actually pick up, if this is something you've done in the past or if this is something you're doing for the first
Shows.
time.
Yeah.
And I think as long as they're happy, I think that's fine.
Yeah. I agree. Totally agree. Has anyone got any specific questions that I haven't asked already? Would be the good chance to ask Ritika. She's very nice. I have to make use of her. Gurmeet Kaur, you've got your hand up. Kaur. Gurmeet, you're you're still muted. Yeah, I don't think she's.
Hi, hi.
Hello, hi.
Hi.
Hi, thank you for organizing this course. And I was looking at the application, and basically, I want to know now. I've opened this, and it says columns like honesty and integrity, relationship with patients. So, what I should be putting in that?
So she's talking about the one of the domains in the actual
Yeah.
application. Many of you haven't actually opened the application, obviously. So it's one of the domains that you need to submit some evidence to. So Ritika, how did you prove this sort of thing?
So, the case book that I showed originally, I put a lot of patient letters in that. And, some of those letters where, there's been a complication and I've explained to the patient, and, everything is put down in the letter. I use that letter to show. So what I'll do is I'll very briefly share my screen, if that's okay, Mustafa. Right. So this is my master sheet for all the learning outcomes. So essentially, I just converted the spreadsheet that college provides into a Word table. And these are all the domains. So these are the assessments I showed, any CBDs. Patient letters are from the case logbook, which you can see they're all sort of labeled according to the number. And any courses, publications, or presentations that I had, I linked them as other evidence here. So if I go down, I think the honesty. Yes, it's things like this, developing a rapport, communicating effectively. You'll see a lot of evidence is from the letters, and there's not really any sign off for this, things like. So basically, I just showed patient letters where I discussed a complication, or where, you've discussed a bad prognosis with the patient, you have listed someone for a surgery, and you have discussed. So things like that you can put and in these sections.
And
I
another,
would add, so I would agree with Ritika. So patient letters are great, but I would add that add the code of the of the sign off at the top. So do not leave it to the assessor to sort of guess. So just put, let's say, C6 or C5 or whatever
Yeah.
at the
Yeah.
top, and write consent or write confidentiality or whatever, just to guide them that this I've associated to this outcome. Do not leave it vague. Do not your aim is to keep it as easy as you can for the assessor. You remember, they're not getting paid at all, so they want it to be very, very smooth. And if they
yeah,
like what you've done, they will give you the whole thing, for the first go. So yeah.
yeah. So basically, because in SSG it is showing like domain 1, 2, 3, 4, but yeah, in application it was showing like this honesty and integrity, health and safety. So I was with like in
Oh,
health and safety.
sorry, okay, I didn't understand. So you mean what you submit in the application, the
Yes,
GMC actual application. Okay.
yes, yes.
Sorry. So in the honesty so when you come towards the end of the GMC application,
Yeah,
what you'll find is that you've already submitted some evidence in other sections which is
yeah,
relevant to this section. So what I did was I just typed on a Word file that evidence relating to this subspecialty has been submitted in blah 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 in this section, and then I just uploaded that one page in that section. So if you are, for example, if you're highlighting any letters which you have already submitted in the, top three, then you
Yeah.
just highlight the page number, or if you have given them a label or a name in that section. And then things like your MSF will come. So MSF
Yeah.
will come in all these sections. So, your communication, honesty, integrity. So MSF you might have already uploaded
Yeah.
before. So you basically just however, I mean, it doesn't matter if it's repetitive, but you obviously don't upload the evidence again and again. You just make a Word document that these evidence have already been submitted in sequence one or section one. And then so this is what I did.
Even
Okay.
even to make it even more simple, you don't have to submit that Word document. You just write, and there is if I remember correctly, there was like a drop down box, and then it says evidence uploaded. I think pending, evidence not uploaded, something like that. So when you click that, and then in the free text box, you write down evidence uploaded elsewhere. Yeah. So
Uh,
you don't have to actually submit a document or whatever file in that domain. So that domain can be empty. However, you have to write down very clearly, as Ritika mentioned, that this has been mentioned elsewhere. You do not duplicate evidence. Do not duplicate,
Okay.
because this is just a
Okay.
repetitive thing.
Okay.
Yeah.
And like in other column, it is health and safety. So I was wondering whether I should be putting like HS1 all there or HPDP something. I was not sure basically.
Yeah. Go ahead, Ritika. Yeah, you're the guest. Go ahead.
So, I mean, I don't think you have to. So, all the outcomes. So, I would make one master sheet, and that would sort of link all the documents that you have submitted with the outcomes. When you're actually uploading in the GMC application, you will upload the documents. So, you don't have to upload specific an outcome linked to
Okay.
HS1 or HPDP,
Okay.
if that makes sense. So in health and safety, if you haven't uploaded elsewhere, you'll have things like your mandatory training, um, and your MSF again, that, there's a column that you take care of your own health and you things like that.
Okay. Okay.
Yeah.
I would add
Got it.
reflections as well. Reflections is a very, very nice, easy way to tick off lots of boxes. Let's say she hasn't submitted a reflective diary. Many of us have. It's like a Word document again. You just write a story that you've faced, what went wrong, what could be better, what did you learn, that sort of thing. That will tick off this box. Okay, so let's say you're rubbish in communication, yeah, but then you had an issue where a patient complained or whatever, and then you reflect on that and how can you improve your communication, and that sort of, let's say, half a page worth of document, that you can link to that tick box and just tick it off. That's it. Yeah, so usually it does work. Okay, but obviously do not submit 100 reflections, but it's a very nice, easy way, because it's your own thoughts. No one's going to go back to your notes and see if you actually done this or done that. So it's a relatively easy way to do it. um, Amr was asking, patient and colleagues feedback forms.
Mm-hmm.
So what sort of MSF did you use?
Yeah. So I just a normal through my appraisal. So we use a format L2P, but you
Yeah.
can also use the Royal College. I don't know how it works on 14 Fish because I haven't used it, but there was a way to do it on the e-portfolio earlier as well. Or you can just use your trust's appraisal, patient and colleague feedback. And that's what I submitted.
How many did you submit?
So it was 25 for each.
Yeah, but only one. So like only
Only
once.
one. Because you
Uh,
do it sort of once in every 3 years.
yeah.
So I submitted sort of within sort of 3.5 years of coming here.
Yeah.
Yeah. So I only
Uh,
submitted one.
okay. I submitted two. One was the MSF from the college, and the other one was the trust appraisal one, and it worked. But I'm not sure. It's not specifically mentioned somewhere, but the patient feedback forms, I'm not sure if that's essential or not, to be honest. Definitely the colleague feedback, which is fine, but I'm not sure about the patient feedback. But even if it's not essential, again, it would be very useful if you can get one done. It doesn't have to be the trust one, by the way. You can get any feedback sort of template from Google
Yeah.
if you want, and then give it to your patients, and then ask them to leave it, anonymously, obviously, with the nurse or something. And then what I've done is I highlighted the comments. Yeah, so let's say this patient mentioned that I'm a good communicator or whatever, I'm patient with them, or I'm whatever, I'm kind, whatever you want. Then you can highlight that, and then you can, guide the assessor that, this will serve as evidence as well.
Yeah.
So definitely useful, even if it's not essential. Okay, so I would suggest one colleague feedback, another patient feedback. That would be very nice. Um, Fine. Any other questions? Prashov was saying that there is a GMC approved feedback form. Yeah, so online, if you Google that, I wasn't aware of that. So you can just Google them. You don't have to use the one on 14 fish or the one on the trust. Any feedback form, and obviously the GMC approved one would be the best one to go to, really. Fine. Any other questions? We've got maybe 10 more minutes less. Should we call it a day? I've finished my questions. Unless Ritika might sort of, what would be your advice? Let's say this is the last thing. What would be your advice for someone who's still starting the journey? What would you advise them? And someone who is on the more tricky sort of spectrum, they're very senior and they're stuck in one place. Okay, that's a very common scenario. They're stuck in one place. They've got a family, they've got a house, schools. They cannot move. Okay, they're not getting the support in the unit, and they don't know what to do. Um, what would be your advice to those people? I mean, maybe let's say they've done their exam, they're happy with their
Yeah.
exam, they're very experienced, but they cannot get the support they need. What do you think? What would you advise them?
I think my understanding is that the main problem with CESR is lack of, awareness about the entire procedure. So when I first joined and I told a few of my consultants that I wanted to CESR, they had no clue about it. So I think it's opposite to training. So you have to bear the burden of knowing everything and telling your assessors that this is what I need and this is how you can help me. So if you're starting out, I would recommend going through the SSG and going through the curriculum to get an idea of what you need to cover in the next whatever couple of years you have set your target as. And then if you can attend one of the CESAR workshops, that's very useful because that gives you an overview. And then you can sort of, mentally and you can organize your evidence and you can organize all the hard work that you do accordingly rather than wasting time. And then I made a list of what all I needed. And then I could actually go and tell people that this is what I need from you. And I think if you if you tell them exactly what you need, in sort of simple terms, for example, I told the squint surgeon that I did that I need so many sign-offs. Obviously, I've done squint in my training, but I think in the first few theaters, I would need a bit of help because I haven't done one for some time. So she figured out a way. She said, okay, I have one theater every month where I don't have anyone. I'd be very happy for you to join me. So we formed, so I think you have to take the lead on it, is what my advice would be. If you are stuck, you make a list of what you need and then sort of, do one thing at a time, pick one specialty at a time, and then, try and sort of tick that off. And I think that worked for me and I found
Remember,
that.
and remember, people have to like you. Yeah. So if most of us
Mm.
as SAS or local consultants, remember this is not a training job. Okay. So actually, the trust, they're not, you know, uh, they don't have to train you at all. This is a service job. Okay. Let's be very honest again. This is not a training job. Theoretically, yes, you want to develop, but it's not part of your job plan to get taught. Okay, so you have to lead on this, as Ritika said. You have to be nice, yeah. So avoid being too pushy. There's a very thin line between, being cautious and being too pushy. You have to find just the right limit for each person. Again, each person has got their own sort of way of doing things. Avoid people who are not helpful. You're not going to use them at all. um, Many people have had to go to other trusts. I don't think Ritika had to, but you can just get an honorary contract with a neighboring trust, and then you can get some stuff that's done there as well. And I haven't done that myself, but I'm sure the managers and the HR would be more than happy because you're doing that for free. So you're coming to the trust working for free, and that's great. So they will really like you. So that is an option as well. Okay, and trust me, there is always a way for those who are really keen to do it, and it's definitely worth it. I'm sure Ritika would agree. It's really worth the effort. It's not an easy sort of pathway. Um, it's definitely worth it at the end. Okay, so being a permanent consultant is totally different than being a locum consultant. Okay, it's a totally different ball game. All right. Um, I would really agree with her mentioning that you have to attend the college training days. I personally attended it 3 times. Once I came to the UK, and then another time before I submitted, okay, and a third time after I actually got my Caesar, before doing these sort of courses and stuff like that, so just for me to be more aware of the new curriculum. Yeah, so attending those are very useful, and Rob is very, very, very helpful, and he's approachable. You can always email him. It's a very good team. Okay, so my sort of take home message is there is no excuse of not doing Caesar nowadays, and they're doing their Suita, who's the SAS chair. She's doing her best. She's fought for lowering the cataract numbers. She's doing her best to help things go forward. There is no excuse. Okay, that's my obviously the exam. Again, some people are struggling with the exam, but there are lots of courses out there. You can just spend the time studying and stuff. So just go on it and fight for it. I think it's definitely worth it at the end. Um, Fine. I sort of I'll stop talking now. And if no one has got any other questions, we can call it a day. So thank you, Ritika, very much. I appreciate it's a Sunday, so I really appreciate it, and people really like doing these things. So hopefully we'll carry on doing them if we can. Um, I will upload this on YouTube soon, maybe tomorrow or in 2 days' time, something like that. And thank you very much again. All
No,
the
thanks
best.
for organizing this, Mr. Fan. Thank you.
That's all right. Always a
Okay.
pleasure. Take care, guys. Thank you very much. Have a good weekend. Bye now.